So good evening, everyone, and welcome to the second talk of our breast webinar series. That is the approach to breast co-biopsy. Our distinguished speaker for today is Dr. Asavari Patel, Professor, Tata Memorial Center, ECTRAC, Navi, Mumbai. On behalf of IAPM Kerala chapter, I extend a warm welcome to Dr. Anita Matthews, Additional Professor and Head, Department of Pathology, Regional Cancer Center, Thiruvananthapuram, to introduce today's speaker. Madam completed her MD Pathology from Government Medical College, Tirunduram, and has 29 years of experience in this field. She specializes in neuro and breast pathology and holds an ICRETT fellowship in neuropathology from Mayo Clinic, Rochester. Additionally, she has undergone training in PCR technique at Kagoshima University, Japan, and completed an observership in pediatric oncopathology at the Royal London Hospital. With over 100 publications in peer-reviewed journals, Madam is also an integral part of many research projects. So over to you, Madam, for introducing today's speaker.
So good evening. And thank you, Dr. Shaini, for that kind introduction. And Dr. Nina and the IAPM for giving me this opportunity for chairing the session. Now it's my pleasure to welcome Dr. Asavari Patel, Professor and Pathologist, ECTRAC, Tata Memorial Center, Mumbai, to deliver the second talk of this webinar series on breast carcinoma. Now the core needle biopsy or the true cut biopsy has become the first preferred procedure for diagnosis of breast lesions, both clinically detected or identified by screening mammography. And the histopathologist, they are faced with the daily challenge of making a definitive diagnosis on this limited biopsy material. And at times, the varied lesions of the breast can enter into the differential diagnosis, and an incorrect diagnosis, be it an overdiagnosis, diagnosing something benign as malignant, or an underdiagnosis, diagnosing something malignant as benign, can adversely affect patient management. Another important aspect of core needle biopsy is the importance of knowing the importance of conserving the tissue for subsequent biomarker study in cases of breast cancer, as this is the ideal material for receptor study in comparison with the excision or mastectomy specimen, which are prone for more liable for improper fixation and suboptimal immunohistochemistry. Now, to enlighten us on this topic, we have with us Dr. Asavari Patel. After completing her MD in pathology in 1993, she worked as a consultant pathologist in academic and private setting in India till 2002. Subsequently, she did her residency in anatomic and clinical pathology at New York Medical College, USA. She did a fellowship in oncologic surgical pathology and breast pathology in Memorial Sloan Kettering Cancer Center, USA, during a 2-year period, 2006 to 2008. She was a diplomate, American Board of Pathology, till 2016. She joined Tata Memorial Center, Mumbai as scientific officer and pathologist in 2008 and continues to be a faculty there. Now, her areas of special interest are head and neck cancers and breast cancer. She is active in several research projects related to these areas. She is a principal investigator in 9 projects and co-investigator in several other projects. She has more than 75 publications in peer-reviewed journals and has contributed to a chapter on intestinal type sinonasal adenocarcinoma as a co-author for the WHO classification of head and neck tumors, 5th edition. She is a member of the editorial review board for Head and Neck Pathology journal, which is published by the North American Society of Head and Neck Pathologists since July 2021. On behalf of the Kerala chapter of IAPM, I warmly welcome Dr. Asavari Patel to enlighten us on this topic. Over to you.
Thank you very much, Dr. Anita, for that kind introduction. I would like to thank organizers of the meeting for giving me this opportunity to discuss our experience in breast core needle biopsy. Are my slides visible?
Yes, madam.
Okay. So this is my disclaimer, nothing, no conflict of interest, and I'm using our hospital material as well as some of the textbook and website material. So today's topic, we are going to discuss CNB core needle biopsy techniques and indications, how to handle them, a brief comment on reporting of breast core needle biopsies. There's one of these points is role of ancillary studies. Most of it is going to be for differential diagnosis, which I'll be discussing, but there is a major role of biomarkers, predictive markers, which will be covered by my colleague, Dr. Ayushi Sahai, next week. We will be also focusing on challenges and pitfalls with some interesting cases diagnosed on breast core needle biopsy. So, what is the role of pathologists in breast cancer management? It is mainly we are required for primary diagnosis initially, which can be with core needle biopsy or fine needle aspiration. And second, our role comes when radical surgery is performed or final surgery is performed, where we are going to give them various predictive and prognostic markers, which can be helpful for decision about adjuvant chemotherapy and radiotherapy. So coming to the techniques for and indications for diagnosis of breast lesions, the two important modalities are FNAC and biopsy, of which core biopsy is the gold standard, why we will discuss later. Now the biopsy can be of many types. It can be core needle biopsy, which can be done under radiological guidance like stereotactic or USG guided, guided or MRI guided. And then there is another modality called as vacuum assisted biopsy, which is a large bore needle, and open biopsy, which is going to be incision biopsy. And this is a picture showing various modalities, especially if you see the gauge of needle increases as we move from FNAC to vacuum needle vacuum core biopsy, and open surgical biopsy is with scalpel. So let's come to the FNAC, which is a very common procedure. Even in India, we see many people using it. And honestly, although for breast diagnosis, FNAC is not a method of choice, we must understand that there are many places where core needle biopsy may not be available as as a primary modality for diagnosis, and where FNAC may prove useful. But having said that, we have to understand the limitations of the FNAC. We know about the techniques used in FNAC, where we use 21 to 25 gauge needle using a syringe and aspirate the material. Now, there are many important advantages that it is minimally invasive, it is rapid, the results are quickly available, it is cheaper, can be done on OPD basis, and most of the times when it is done and with experienced person, the results are good, there are many disadvantages. One thing is it is smaller sample size. It is less sensitive than core needle biopsy because it lacks the architectural information. Our diagnosis of breast lesions, architectural information is very important, which we are going to see subsequently in various cases. Again, if we call it, if we need ISC for any diagnostic purpose or for biomarker purposes, for which we need a tissue specimen, ISC is standardized on histology, and ISC is essential in breast cancer before going for definitive therapy because the therapy is planned based on the biomarker testing. So when it comes to breast cancer diagnosis, FNAC has a limited role. One thing we must understand, if any case is diagnosed as breast carcinoma on FNAC, the next thing we have to insist is get one core needle biopsy, a good specimen, very well fixed specimen for further studies. Core needle biopsy is, which is a larger bore needle, usually 12 to 14 gauge, and that can be done at by most of the times surgeons they do it with the experience. They can get a very good core. There are many advantages as compared to FNAC. The gauge, the Size is needle gauge is it is wider, but it is less invasive than open biopsy. It gives more definitive diagnosis. We can perform immunohistochemistry for biomarkers. Any additional ancillary studies, if molecular studies are required, any IC required for definitive diagnosis, everything can be performed in core needle biopsy, which is not possible on FNA. So definitely, core needle biopsy provides information for planning further therapy, which is not possible with FNA. There are certain disadvantages. It is more expensive than FNAC. Sampling error may occur. It can be difficult, especially when the lesion is located in subareolar region or near pectoral muscle. But again, these problems can be avoided with experience in biopsy techniques. One, we need to understand this is a standard procedure, gold standard for suspected cancer cases. And this can be done either directly using uh, the instrument, having the cannula and needle, or that can be done under guidance of ultrasonography or MRI. And here the lesion can be located when it is deep, and the biopsy can be obtained. And this is how it looks like when we get the course of the biopsy, which needs to be fixed immediately in 10% neutral buffer formalin. What are the indications for breast biopsy? Palpable breast lesions or radiologically suspicious lesion, which can be a mass lesion, architecture distortion, suspicious calcification, sometimes complex cystic lesion. Now, radiological lesions, for that we know, most of us are aware about, there is this radiological interpretation, which is divided into certain categories called as BIRADS categories, and of which this table enumerates all the BIRADS categories, of which it is the category 4, which is suspicious, or category 5, highly suggestive of malignancy. These are the two categories which will need a tissue diagnosis. There can be because these can have some likelihood of malignancy. Category 4A has least likelihood, but category 5 is more than 90% likelihood of malignancy. So in these cases, we may get the breast core biopsy. Having said that, the situation is different in India when compared with the Western population, because in Western countries there is a routine uh, screening is done for with mammography. So the incidence of having breast core needle biopsy for low suspicious of malignancy lesions is more. We may get some cases of like UDH or usual ductal hyperplasia, atypical ductal hyperplasia, sometimes DCI, sometimes calcification in benign breast, because any suspicious calcification may go for biopsy, which is not the case in India. Most of our cases, we had the biopsy is done when there is palpable lump, sometimes radiologically detected lump. So with this, let's go to our how to deal with the core needle biopsy. And it's a monsoon time. Pune Mumbai express highways has some scenic um, areas. It's a very nice place to travel in monsoon time, during monsoon time. Coming to handling of core needle biopsy, when first we get this biopsy specimen, we should make sure that the request form includes demographic details, exact site of biopsy, indication for the biopsy, including clinical and radiological findings. Please insist on that, because that can help you to make sure that you are getting a representative biopsy and not something which may not be representative, which can lead to diagnostic discrepancy. Then what is the type of biopsy, whether it is core-needle biopsy or vacuum-assisted biopsy, incision biopsy? Vacuum-assisted biopsy usually has it has bigger volume of tissue and may have some blood clots. So we need to separate out blood clots. They need to be submitted or processed, but we can sample the tissue core samples separately to make sure that blood clots do not mask the important findings. One more thing important, which we have to insist with our clinicians or surgeons, that the cold ischemia time should be less than 1 hour. What is cold ischemia time? It is the time since the tissue is taken out of body and transferred into the formalin, which should be actually in minutes. but less than 1 hour is minimum required. It should not exceed more than 1 hour. As far as possible, the moment the tissue is procured, it should be transferred to 10% neutral buffer formalin and should be fixed minimum for 6 hours, maximum for 48 hours, which will, why it is important, because this is necessary for proper antigen, which should not be create any problem later on for preservation of antigen, even for DNA or RNA, DNA or RNA processing. So once we receive the tissue course, we have to, if there are multiple courses, best thing is to divide into at least 2 blocks or more than that. The reason is all blocks can be studied microscopically, but when we want to do ancillary studies, nowadays the ancillary studies are required even later on, because with additional prognostic studies and predictive markers coming up, patient may come to you later on that I need my previous block and I need to do this and that study. Now, that time it should not happen that we have exhausted all tissue with our previous ISC studies or even molecular studies. So it's always it's a good practice to divide the tissue in multiple blocks and study it and select the best blocks for further ancillary studies. Try to get initial HE section, try to get at least one level is important, but try to get more levels if there is any suspicion or if you require step sectioning can be done. Then further ISC studies are done, which could be ISC or even in situ hybridization or multigene assays. So we have already gone through this reporting of core renal biopsy now. So while reporting, again, confirm the patient identifier, type of specimen laterality, time of specimen removal, and time of formalin fixation. Check the gross examination. Check the clinical findings, if possible, radiological findings. In Tata, we are privileged that we have electronic medical record, so we can always go back and check it. While coming to microscopy findings, a definitive report can be issued in majority of the CNBs, and the final diagnosis usually falls into one of the following categories like normal or benign pathology or neoplastic pathology, malignancy, and some of the cases may be difficult, which may not be categorized any of the above. These are the gray zone cases. In general, the core renal pathology report can be categorized into 5 categories. It is nicely explained by Dr. Ellis and his group in 2004. These categories are B1 to B5. As you see here, B1 is the normal tissue. B2 is benign lesion, which can be fibroadenoma, fibrocystic changes, or fat necrosis. B3 is uncertain malignant potential, especially when we are looking at papillary lesions or atypical ductal hyperplasia or radial scar. Even phyllodes tumor, we may not know whether it is malignant versus borderline or benign. B4 is suspicious. Suspicious for malignancy, but is not diagnostic. And this can be due to many reasons. It could be because of poor fixation or scanty tumor tissue, or could be some artifacts. And B5 is malignancy, which is definitive malignancy diagnosis, which can be invasive breast carcinoma, DCIS, or any other malignancies where we need to do further studies. So this is one of our cases showing your benign breast tissue. There is little bit areas of adenosis and you may get some calcification. Now, when you look at the invasive or breast tumors, they are further classified into multiple categories as per 5th edition. This can be epithelial tumors, and fibroepithelial tumors, tumors of nipple, mesenchymal tumors, and hematolymphoid tumors. The commonest one which we come across is invasive breast carcinoma, ductal carcinoma, and situ, and also fibroepithelial tumors, especially fibroadenoma, sometimes phyllodes tumor. Among the benign condition, we may come across epithelial proliferation of fibrocystic changes, while rest of the tumors are, and papillary neoplasms as well. Rest of the tumors are not so common, but we do get them sometimes in the biopsy. Again, invasive breast carcinoma, there are multiple types They are listed in this slide. You can see that there is no special type. There are multiple special types as included here on the left hand side. Then there can be rare salivary gland type tumors, neuroendocrine neoplasms, and papillary carcinoma is further divided into three categories. One is encapsulated, second is solid papillary, which can be invasive or in situ, and invasive papillary carcinoma. So whenever we are dealing with a breast cancer biopsy, the microscopy findings for breast carcinoma should include all these points. First of all, whether it is invasive breast carcinoma or DCS only. If it is invasive breast carcinoma, what is the type of invasive breast carcinoma? It is no special type or any other special type. Try to grade the tumor in the biopsy if possible. I say if possible because sometimes there could be less tumor where you may not be able to count the mitosis. Sometimes the fixation or artifacts issue may be there. So if we can give grading, we should give. If we cannot give grading, we try to, in a scanty tumor, usually we try to give nuclear grade at least. When DCS is present, absent, or present, or when present, we have to go for type of DCS, nuclear grade, necrosis. Lymphovascular emboli, when present, we have to mention them. If absent, even if you don't mention it, that's fine. Microcalcifications, we have to remember that many times the biopsy is done when the radiologist sees microcalcification. So if they are present or absent, we have to mention. If they are present, where they are present, whether they are in normal breast or benign breast tissue, whether they are in DCS or invasive breast carcinoma. And lastly, important topic is immunohistochemistry for biomarkers, which will be covered again next week by my colleague. Coming to the grading of breast cancer, we are all aware of this grading, modified Broom Richardson score, which includes tubule score, nuclear pleomorphism, mitotic count, and final grade is grade 1, 2, or 3. And this is the most commonly seen photograph from Dr. Rakha's publication, where you can see grade 1, grade 2, and grade 3 tumors. Grade 1 has more tubule formation, grade 3 has almost no tubule formation, and the nuclear grade is also higher. This is one of our cases showing grade 1 tumor. This is another grade 2 tumor with some mucinous component. And our case grade 3 tumor, where this was a triple negative breast carcinoma. Uh, So coming to ductal carcinoma in situ, when we see ductal carcinoma in situ, we have to describe what is the type or architecture of the DCIS, solid or comedo type or cribriform type, and so on. Nuclear grade, whether it is low, intermediate, or high. Necrosis, whether present or absent. If present, whether it is a focal necrosis or comedo type necrosis. Remember, these are the solid or comedo type of DCIS with high nuclear grade and comedo type of necrosis. These are the worst category. And nuclear grade and presence of necrosis are most predictive of the outcome. So this is one of our cases showing ductal carcinoma in situ, solid type, high nuclear grade. You can see here case with DCIS with comedo-necrosis, and this is a cribriform type DCIS. This is micropapillary type DCIS. So architecture of DCIS and nuclear grade and necrosis needs to be mentioned in every report whenever possible. If our biopsy shows only DCIS, no invasive carcinoma, please mention that no invasive carcinoma identified in this biopsy. If focus of suspicious for invasion is there, we can always do some myoepithelial markers and look for or confirm the microinvasive focus. So there could be many challenges while interpreting the breast cord needle biopsy. Problem will be when we have ductal hyperplasia, whether it is usual type or atypical ADH or atypical ductal hyperplasia. Sometimes atypical ductal hyperplasia versus low-grade DCS can be a problem, how to differentiate between them. Papillary lesions is another category where uh, may be difficult sometimes to say whether it is intraductal papilloma, whether it is papillary carcinoma in situ, whether it is invasive papillary carcinoma, solid papillary carcinoma, invasive or in situ. So these categories we may not be able to differentiate them, and sometimes our report can go as papillary neoplasm, and the final diagnosis will be given on the excised tumor, where we have enough of tissue. We can look at the periphery of the tissue. and whether it is invasive in situ, whether it is papilloma versus DCIS, that can be better interpreted sometimes on in excised tumor rather than biopsy. Having said that, we can give some diagnosis many times on biopsy, whether it is papilloma versus papillary carcinoma. Again, fibroepithelial neoplasm. Fibroadenoma, diagnosis of fibroadenoma or phyllodes tumor may not be a problem if we have a representative tissue core, but if there is a cellular stroma in a fibroadenoma, we may not be able to differentiate between cellular fibroadenoma versus benign phyllodes tumor. Again, when there is a phyllodes tumor, differentiation between benign and borderline and malignant may not be always possible on biopsy because there are various other factors which come into play while deciding one over other. Same is true for spindle cell lesions. The differential diagnosis again it has a wide spectrum of differential diagnosis. It can be a low grade. If it is low grade, this can be low grade metaplastic carcinomas. High grade can be sarcomatoid carcinomas, malignant phyllodes tumor, any other spindle cell sarcoma. So here again, immunohistochemistry and trying to look for epithelial components is important while distinguishing between the two. Again, radial scar and complex sclerosing region may be a problem distinguishing between the two on a breast core needle biopsy. So with these problems, we know about like how to go ahead. How can we use ancillary studies for them? So besides ERPR, HER2 and other markers for therapy, which aid in therapeutic options, there are many immunohistochemistry markers which can help us in diagnosis. So this could be myoepithelial markers like P63, P40, SMSC, and calponin. They are useful in differential diagnosis of papillary lesions of breast, to diagnose a microinvasive carcinoma versus DCIS only. Also in complex sclerosing lesions to differentiate between invasive carcinoma and sometimes complex sclerosing lesion, which can mimic invasive carcinoma. In case of lobular neoplasms, like invasive lobular carcinomas and variants, or lobular carcinoma in situ, E-cadherin, sometimes beta-catenin can be used for diagnosis. There are various specific types of breast malignancies. For example, adenoid cystic carcinoma, we can use certain markers. Secretory carcinoma, we can use certain markers. Same is true for other non-carcinomatous malignant tumors like melanoma, sarcoma, lymphoma. All these diagnostic markers are available for all these conditions, which we can use them for accurate diagnosis. Spindle cell neoplasms, again, differential between sarcomatoid carcinoma versus malignant phyllodes tumor and sarcomas. We can use immunohistochemistry. So a wide range of immunohistochemical panel is now available for distinguish between to distinguish between various conditions or various breast lesions. And one of these papers which has been published recently by Dr. Ayushi, my colleague. This is in 2022 in Indian Journal of Medicine and Pediatric Oncology, which can be helpful for your further reference. To summarize, if we are looking at spindle cell lesion, so low-grade lesions will have certain set of markers, like as you see here, we can use epithelial markers, CD34, desmin, and so on, SMA, BCL2. While if you look at the high-grade spindle cell tumors, there are again cytokeratins and other sarcoma markers, including S100. You can have, we can use melanoma markers. Spindle cell melanoma can be a problem. So various markers can be helpful for distinguishing these different neoplasms. This is one example you can see here. This is in the case of invasive pleomorphic lobular carcinoma, A1, A3 is nicely positive, highlighting the tumor cells. But if you see this E-cadherin is negative, in some areas it is positive, which is a benign internal control, indicating that the ISC is working, but it is negative in the, or the expression is lost in the tumor cells. Similarly, this is a sarcomatoid carcinoma with osteoclast like giant cells, and we can see that A1, A3 very focally positive, but EMA is positive, epithelial membrane antigen is positive. So a battery of immunohistochemistry panels is usually required for a definitive diagnosis. Coming to papillary neoplasms, how we can utilize them. If you see the categories included under papillary neoplasms of breast, they can range from benign to malignancy, which can be intraductal papilloma, in situ papillary carcinoma, solid papillary carcinoma, and invasive papillary carcinoma. Now, again, you can see here, there are various myopithelial markers can be used for diagnosis. Usually, we have to look at the papillary course and the periphery of the papillary tumor. If the myopithelial markers are positive, it is usually benign, or sometimes the morphology, if it is indicative of DCIS, we can at the most call it as DCIS, but not definitely invasive tumor. When it is invasive tumor, it is the myopithelial markers are lost in the papillary course and they are also lost at the periphery. But it can be encapsulated, although there may not be any myopithelial markers there present, or sometimes it can be frank invasive carcinoma. Sometimes it can be only when the myopithelial markers are only lost in the papillary course and positive at the periphery, where it can be diagnosed as a DCIS based on the, again, morphology is the first important clue. Anything without morphology, we are not going to make any diagnosis without morphology matching the final diagnosis. So first we have to look at the morphology, and then only we have to judiciously select the immunohistochemistry panel for further differentiation. Again, ER can be helpful sometimes for definitive diagnosis, especially benign conditions like intraductal papilloma can have patchy ER expression, while most of the DCIs and carcinomas, they have diffuse strong ER expression. So this can be used as a surrogate marker. So just to give an example, this is the top picture is a papilloma. You can see P63 is nicely maintained in the papillary course and outside, while papillary carcinoma, P63 expression is lost, which is seen in the two pictures at the bottom. This is one of our case of, again, papillary carcinoma. You can see at higher magnification, you don't see any myoepithelial cells. So again, morphology is very important. We have to try to identify whether there are myoepithelial cells or something resembling myoepithelial cells are there or not. We are not sure whether there are any myoepithelial cells, but most likely they are not there. And as you see here, P40 SMSC is lost. CK56 again, which is another myoepithelial marker, which is not present, but ER is diffuse and strong. Coming to biomarkers and molecular tests for breast cancer, which is needed for further selection, appropriate selection of therapy, we'll have discussion in next week. So I'm just going to skip these slides. And this is Mumbai coastline during monsoon. Let's look at now some interesting cases where we have used sometimes these different markers and how they can be helpful in diagnosis. So first case is a 50-year-old female, which is a right breast lump, 6 centimeter. On mammography, there was a large irregular mass with adjacent breast showing architectural distortion, which on ultrasound showed heterogeneous mixed echogenicity. Now there was this biopsy, there were two biopsies. We got a biopsy from the mass itself as well as architectural distortion area. So from architectural distortion, if you see, this is the biopsy where you can see some sclerosing lesion. There is something at the top on the right hand side. We are not sure what it is, but some kind of sclerosing lesion is there. Some benign breast tissue with some microcalcification. Here is the sclerosing lesion we see, and there is some spindle cell proliferation at the periphery. You can see there is this sclerosing lesion. We have some cores which could be fibrovascular core or not. We are not sure. Can I say there are some myoepithelial cells? Maybe, but we are not sure. Maybe there are some myoepithelial cells at the periphery of the lesion. Again, here, if you see the other part of the lesion, clear-cut myoepithelial cell layer is visible. You can see this cells with vacuolated cytoplasm at the periphery, and the luminal cells are clearly seen towards the luminal side. So most likely this is a benign papillary lesion. We have some fibrocystic changes, include some microcalcifications in the breast, as you see here in the at the higher magnification. Here is the microcalcification. So then there is this second mass, which was a biopsy from the other mass, and you can see here some leaf-like arrangement with cellularity, increased cellularity, which is looks like a stromal cellularity. And if you see the epithelial component doesn't look malignant, but definitely it has a particular arrangement. If you look at the stroma at higher magnification, definitely there is some nuclear atypia, but we don't see uh, mitosis that many. It's difficult to assess the mitosis sometimes in the biopsy, but it's a 6 centimeter mass, stromal cellularity increased. We have a stromal cell atypia. So our diagnosis is going to be Phyllodes tumor, at least of borderline type. Or borderline Phyllodes tumor with a comment that cannot exclude malignancies, fine too. While the first lesion was intraductal papilloma with sclerosis. Now here, because we saw enough myopithelial cells, we didn't use any immunohistochemistry. But if you are finding it difficult to look for myopithelial cell, we can definitely go for immunohistochemistry. Second case is a 51-year-old female fungating mass, 16.5 centimeter. We don't see any axillary nodes palpable, and biopsy from mass is there. You can see here, you can clearly make out even at this magnification, probably there is stromal overgrowth. But we do find some benign epithelial component as this is shown by this red arrow. You can see stroma is quite cellular. There is stromal cell atypia, at least moderate or maybe sometimes higher grade, but benign epithelial component. Now, this is a clue. When we get a spindle cell tumor with a benign epithelial component and typically showing intracanalicular type or some pericanalicular type or some leaf-like arrangement, this aids in diagnosis of fibroepithelial neoplasm. Now, particularly this case where there is 16 centimeter mass, high cellularity, stromal cell atypia, our diagnosis is going to be again Phyllodes tumor. We are looking for mitosis, not so often. It's difficult to get them. So we said this was a Phyllodes tumor. Differentiate between borderline Phyllodes tumor and malignant Phyllodes tumor. We cannot differentiate because we have to understand in a 16 centimeter tumor, a small core is not something really going to decide whether it is borderline versus malignant tumor. So that information needs to be conveyed to the surgeon that it is at least borderline but cannot rule out malignant Phyllodes tumor. Why it is problem? Because we are aware of this classification and various characteristics which help to differentiate benign from borderline and malignant Phyllodes tumor, of which in a biopsy we can assess cellularity, atypia, sometimes microtic activity, malignant heterologous component if it is present may be helpful. Stromal have overgrowth sometimes, but we cannot really assess the tumor border. We cannot really assess the heterogeneity. So in that case, differentiation between these three types may not be always possible. Even differentiating cellular fibroadenoma from benign Phyllodes tumor may not be possible. The reasons are as that age of the lesion may not be included, so we cannot say whether it is infiltrative versus well-defined, well-circumscribed tumor. And this we have already discussed. Further categorization of Phyllodes tumor can be very difficult, as the stroma can be usually non-uniform. We have to look at multiple tumor sections to look for number of mitosis and malignant heterologous component. The clues usually are age of patient, size of patient, radiological finding. So because as in a young age, smaller, well-circumscribed tumor, most likely it's going to be fibroadenoma. While larger tumor in a middle-aged woman, lobulated tumor, it's going to be most likely Phyllodes tumor. And again, presence of malignant spindle cell, marked increase in mitosis, all these factors can help in diagnosis of uh, malignant Phyllodes tumor. So Western Ghats near Sahyadri ranges can be again a beautiful sight during monsoon. And this is waterfall, Thosegar waterfall. Coming to our next case, 60-year-old postmenopausal female presented with right breast lump and lower inner quadrant, 2 centimeter lump with irregular calcification. It was called Barrett's 5. And you can see this tumor, quite tubular arrangement. Now, whenever we look at this kind of tumors, just go on higher magnification. There are tubule formation, nuclear grade is quite low. What we have to look for is myoepithelial cells. Are there any myoepithelial cells at the periphery? No, we don't think there are any myoepithelial cells. Any question or any doubt about it, we can just use myoepithelial marker like one nuclear marker, either P40 or P63, and one a cytoplasmic marker like SMSC or calporin would be useful. Loss of myoepithelial cell means this is infiltrative tumor. It's a low-grade carcinoma. It was a invasive breast carcinoma tubular type grade 1. Now, further ancillary studies are required. ERPR, HER2, Cas67 may usually we do it if it is well fixed. Those patients who can afford, they can go for multi-gene assays. Another case, 34-year-old female, 5.5 centimeter tumor with matted axillary nodes and diffuse increase in parenchymal density on mammogram, while ultrasound showed ill-defined heteroechoic mass. You can see here, again, this is an infiltrative tumor. If you look at the tumor cells, they are there's a particular arrangement, they are in the nest. There is some retraction artifacts. You can see that tumor cells have nuclei pointing out towards the periphery. And this is typical, what we call it as micropapillary arrangement. If you see more than like majority of the tumor having micropapillary arrangement, we can suggest the diagnosis of invasive micropapillary carcinoma. But if you have this micropapillary arrangement only in part of tumor, we can just suggest invasive breast carcinoma with focal micropapillary feature. So this was a case of invasive micropapillary carcinoma grade 2, and further ancillary studies we did perform were ERPR and HER2/neu. Another case is a 53-year-old female, lump in breast, 6 centimeter mass, high density lesion with obscured margin in mammogram. Now we have looked at some of these uh, tumors so far having tubular configuration. Let's look at this tumor, another tumor with tubular configuration. You see, if you see here, majority of the part of the tumor has some kind of tubular configuration. If you look at the lower right-hand side corner, there is some sheets. The tumor cells are arranged in sheets. Higher magnification, you can see that this is formed by tubules. Now, this morphology is something different. Now, what do we call it? This has some tubular configuration. Somewhere it is showing some cribriforming. We don't see, probably there are no myoepithelial cell. And I can assure you, if you do myoepithelial cell markers, it's going to be negative. With a caveat, if you use S100 as a myoepithelial marker, you will see that S100 will be diffusely positive in these cells. Higher magnification, you can see these are the tubules. At places there is some nuclear atypia. There is some of the tubules have some secretions inside them. Some of you must have now probably diagnosed this condition, but you can see now there are some of the tubules are showing really nuclear atypia, which is kind of a worrisome. It is becoming like a malignant one or at least atypical. And here we have full-fledged developed DCIS and invasive carcinoma with lot of mitosis. So basically this is an invasive carcinoma, but what about those tubules? And if some of you may have diagnosed it correctly, this is invasive breast carcinoma, no special type grade 3 associated with microglandular adenosis. Now, this is very important to diagnose microglandular adenosis because first thing, it is very uncommon. Second is it can affect women in a wide age group, but it can present as a palpable tumor and can mimic as a carcinoma clinically as well as pathologically. So if we don't have a good tumor sample, if the morphology is not good, processing fixation is not good, we are going to miss this. We may call it as a low-grade carcinoma, which is not the case. This is yet benign condition, but myoepithelial markers are not going to be useful because they lack the myoepithelial markers. but S100 can be positive. It's going to be positive and ERPR HER2 negative. So it's very likely that we may end up calling this as a invasive breast carcinoma rather than microglandular adenosis or MGM, which is reported in 20 to 27% of cases, and it has carcinoma associated with MGA can be seen, which shows varied morphology. The carcinoma is again triple negative. They say it is favorable prognosis, but with Ayushi, we did a study, we haven't found that much favorable prognosis. And this is our C-link, Worry C-link in Mumbai. Next case is a 50-year-old female, 58-year-old female with lump in breast, 6 by 5 centimeter hard lump. And we have seen this case earlier when I was explaining role of immunohistochemistry. You can see this is a high-grade malignant tumor, lot of osteoclastic giant cell, sarcomatous appearance, brisk mitosis. Now, whenever we get this kind of tumor, the differential always is between sarcomatoid carcinoma, sarcoma, and also malignant phyllodes tumor. In that case, in biopsy, it may be difficult for us to differentiate between the two. A1, A3 was very focally positive, but EMA is nicely positive. Now, this very focal positive A1, A3 can be a caveat because sometimes it can be seen in a phyllodes tumor. So we have to make sure that we are not missing any phyllodes tumor. So this was a case of metaplastic carcinoma with osteoclast-like giant cells, ERPR HER2 negative. And my apologies, I think it got duplicated. So there was another this case, 48-year-old female, 5.5 centimeter tumor with matted right axillary nodes, and a mammogram showed well-defined lobulated high-density mass. Here again, you see this tumor, a very blue tumor, spindle cell morphology, brisk mitosis. You can see multinucleated giant cells, very anaplastic looking cells. And there are some areas which may look like invasive breast carcinoma, no special type, especially in the upper part of the um, picture. A1, A3 was positive in certain areas, while the NST type showed nice A1, A3 positivity. And this was a metaplastic carcinoma sarcomatoid type, which showed both NST component a little bit and majority was sarcomatoid type of a component. So again, malignant mesenchymal tumors of breast, there are differential diagnosis can be between these metaplastic carcinoma, malignant phyllodes tumor, sarcomas, and spindle cell melanomas, and a wide spectrum of immunohistochemical marker can be used. One of them is cytokeratin, and also sarcoma markers and melanoma markers can be useful. So these are some of our cases showing phyllodes tumor on the right hand lower corner. There is this metaplastic carcinomas and sarcomas. So top one is the metaplastic sarcomatoid carcinoma, and the bottom one two were phyllodes tumor, which were borderline or malignant phyllodes tumor. So why it is important to diagnose this in core biopsy, and how do we diagnose them? First, look for epithelial component. If DCIS is present, any epithelial differentiation is present. Having said that, all epithelial markers can be negative, and differentiating spindle cell sarcoma and malignant phyllodes from metaplastic or sarcomatoid carcinoma can be very difficult clinically, but it is important, and whenever possible, we have to make sure that we can differentiate between them, because if it is carcinoma, it will go for axillary lymph node dissection or sentinel node biopsy, and the chemotherapy for both carcinoma and sarcoma is different. So we need to be specific with our diagnosis, although it may not be always possible on core needle biopsy. So we have to remember always that ISC must be interpreted in the light of morphology, especially for spindle cell carcinomas or sarcomatoid carcinoma. We have to use a panel of antibodies. Mainly it is the epithelial markers, and rest of them include sarcoma markers. Marine lines, another beautiful scenic area in Mumbai. Coming to next case, which is 57-year-old female. There were two masses in the right breast, 6 centimeter and 3 centimeter, and left breast had one more mass, that is 4.5 centimeter. Axillary lymph nodes were palpable. Bilateral breast biopsy was done. And you can see this again, blue tumor, very blue tumor. Now, with our protocol, we always do when it is malignant, we do ERP or HER2. So it is easily to pass it or like triple negative carcinoma. But looking at the morphology, there is a problem that we should understand that it doesn't look typical epithelial tumor. If you see, we have to rule out other malignancies, non-epithelial malignancy. So we have to use ISC panel, round cell tumor ISC panel. One of them includes lymphoma markers and also round cell sarcoma markers. Looking at the morphology, we tried lymphoma markers, CD20 diffusely positive, Ki67 high index. This was a diffuse large cell B cell, diffuse large B cell lymphoma. Now, why it is important? Because it may be mistaken for triple negative carcinoma, but it is necessary. It is important to identify these tumors because the definitive treatment is completely different. If it is lymphoma or small round cell sarcoma, patient will upfront go for chemotherapy. While for carcinoma, there will be surgery with or without chemoradiation or maybe neoadjuvant chemotherapy with surgery, but the protocols are different. So high index of suspicion and immunohistochemistry is very useful for differentiation. Now, some of my last few cases, this was a 56-year-old female. She again presented with bilateral breast lump. And when we got the FNAC, initially it was called as carcinoma cell and it, then we asked for a biopsy. And as you see here, this is the biopsy, again cellular tumor. It looks like an epithelial tumor, and with our protocol it was triple negative, so again easy to pass it as a triple negative carcinoma. But something was bothering us. If you see the morphology, you can see the nesting pattern, somewhat trabecular pattern. If you see closely, although we don't see the nuclear features that good in this biopsy, but still it was not a typical invasive breast carcinoma, no special type. So we did some ISC markers. CK7 was completely negative. Synaptophysin nicely positive. Chromogranin nicely positive. S100 again, it was focally positive. Ki67 rather high. So it was called as, now we were about to call it as neuroendocrine carcinoma, but then bilateral breast masses, bilateral axillary region. So let's look for, get more additional clinical findings. And we looked at the PET-CT findings. There were multiple liver nodules. There were lung nodule, lytic lesions in the vertebra, and there was a lesion mass in the tail of the pancreas. So the final diagnosis, when we looked at the liver biopsy, it showed the similar appearance. So this was again metastatic tumor, probably because multiple liver nodules and neuroendocrine carcinoma. Final diagnosis in this case was neuroendocrine carcinoma pancreas with metastasis to breast, liver, and lung and vertebrae. Now this is very easy to miss. So any deviation from usual morphology in invasive breast carcinoma, we should think about other malignancies. We should think about any metastasis from extramammary site. So one more case we had, similar case. Again, triple negative, very easy to pass it as triple negative carcinoma. Nobody does pan-cytokeratin on each and every invasive breast carcinoma biopsy, am I right? But then this case, triple negative, but it shows something. If you see at the center, there's something brownish. Again, there is some brown pigment in the left-hand corner. Now, because of this, we did some markers, S100 positive, melana positive, HMB45 positive. This was a melanoma. Another case. Now, this is another case. It was ER positive. If you look at this case, it's difficult to differentiate this from any invasive breast carcinoma. What is the caveat here? Most of the times you may not find any definitive clue. In this case, first of all, the nuclear grade was somewhat high, very high. At some point, you can see really ugly looking nuclear, as you see here. We did find some calcification, pseudomatous calcification. ER was nicely positive, but there was a history. There was a history that the patient had ovarian mass. So we did WT1, which is positive, and this was ovarian serous carcinoma, which was metastasizing to breast. So this is one important aspect we need to remember. Although it is very rare, but up to 2% of all breast malignancies can be metastasis from other sites. Besides non-hematological metastatic tumor, we can get carcinomas, melanomas, sarcomas. If it is carcinoma, the commonest metastatic site is ovary. It can be GI tumor, gastrointestinal tumor. It can be lung tumors, lung carcinoma. So clinical history and IC panel and unusual morphology is helpful, especially bilateral breast lumps, prior history of malignancy, PET CT showing other areas which are lighting up and are abnormal. All these things should be taken into consideration. Having said that, it's very easy to miss, especially if it is adenocarcinoma, which may be indistinguishable from invasive breast carcinoma. And especially when it is ovarian, it can be ER positive, and we may not even know that it is metastasis from ovary. So with this, concluding my talk, the take-home message here is core-needle biopsy is standard of care for diagnosis of breast lesions and suspected neoplasms. Adequate fixation is essential. Pathology reports should include all information essential for further treatment, clearly indicating whether it is benign versus malignant whenever possible. Correlation with clinical radiological findings is essential. If it is not matching, we have to ask for another biopsy. There has to be always comment that radiologically it says this is a big tumor and this present biopsy may not be representative. Ancillary studies play important role not only in diagnosis but also for predictive as a predictive markers and in therapeutic decisions. I would like to thank my colleagues, Dr. Sangeeta, Tanuja, Ayushi, Trupti, Poonam, our fellows and residents, especially our histotechnicians in Tata Memorial Center and ACTRAC. Whatever the photographs you have seen is their hard work. And of course, our breast disease management group, which has helped us to keep ourselves updated all the time. Thank you very much again, and I'm ready to take any questions. Uh, this is Gateway of India, and this is Pratapgarh, one of the forts of Chhatrapati Shivaji Maharaj. And this is our ACTRAC at Navi Mumbai. Even monsoon, this looks beautiful too. Thank you very much.
Thank you, Dr. Savary, for that wonderful presentation. The cases were indeed beautiful, very illustrative. You have covered almost the varied lesions. Thank you for the excellent cases.
Thank you very much.
And can we go to the question answer session? Okay, Dr. Manoj wants to know the difference between warm ischemia time and cold ischemia time.
See, cold ischemia time is something when we take it out the tissue. When we take it out the tissue, which is the most important one, and we take out of the body and we are going to put it in the formalin. That's the main portion which is going to be worse for tissue fixation and processing and the preservation of the antigens and other markers. So this has to be minimum as much as possible.
And there is another question. Somebody wants to know your experience on neuroendocrine tumors of the breast versus invasive carcinoma with neuroendocrine differentiation. I think when we call it as a neuroendocrine carcinoma of the breast primary versus a carcinoma with neuroendocrine differentiation. Is there any cutoff for that?
Though there is no cutoff, but that's a good question because if you really start ordering neuroendocrine markers in certain tumors, especially solid papillary carcinomas of breast or some of the mucinous carcinomas, especially type B1. So those ones may show some in neuroendocrine marker positivity. That doesn't mean it's a neuroendocrine carcinoma. So if you see if you see a panel of immunohistochemistry, you can see that there is even if your pancytokeratin is nicely positive, ERPR usually can be positive, and you will see synaptophysin and chromogranin, all these neuroendocrine markers, usually focally positive in those tumors where we call it as invasive breast carcinoma with neuroendocrine differentiation. Now, it doesn't matter whether the neuroendocrine markers are positive or negative in these cases because the prognosis and therapeutic decision is going to be based on the grade of the tumor, size of the tumor, and ERPR HER2 status. and sometimes Ki67 status. So on the other hand, if you see neuroendocrine carcinomas, we have seen neuroendocrine carcinomas at many places, like in lungs and other parts of body, where we have that A1, A3 has typical dot-like appearance. These will be triple negative tumors. This will have chromogranin and other neuroendocrine markers nicely positive. So here again, the morphology is very, very important. Morphology, which is closer to invasive breast carcinoma, no special type or any other special type, such as solid papillary carcinoma, having some neuroendocrine positivity doesn't make it neuroendocrine carcinoma. On the other hand, if you have a nice morphology, the one which I showed you, like nesting pattern, trabecular pattern, or higher grade tumors where we have small cell carcinoma or large cell carcinomas with typical morphology, and A1, A3 or PAN-CK is not nicely positive, neuroendocrine markers are positive, and Ki67 we usually do, and ERPR are HER2 negative. In that cases, those will be neuroendocrine Mars carcinomas. They are very, very rare. Neuroendocrine tumors also, they are low-grade tumors, but they are very, very rare. You do get them, but they are very rare in breast. Not like other organs.
Have you seen any primary small cell carcinoma or large cell carcinoma of the breast?
Not yet. I haven't. But having said that, that doesn't mean that doesn't exist. I think one of my colleagues, I think Tanuja may have diagnosed that earlier, but I'm not sure. I haven't seen that.
Ma'am, I have seen one small cell carcinoma of the breast. This is Dr. Ayushi.
Hi,
One
Ayushi.
small cell. I have seen one small cell carcinoma of the breast. And main thing is, if you see a neuroendocrine carcinoma, as madam said, because they are very rare, first and foremost, you have to rule out metastasis before considering a primary. If there is a proper small cell carcinoma of the breast. The other thing, another neuroendocrine tumor that I have seen in the breast is a Merkel cell carcinoma, which actually it is basically, you can have Merkel cell carcinomas. Basically, it's a neuroendocrine tumor of the skin. So that particular lesion happened to be in the skin of the breast. It is, I would still not call it as a primary, a neuroendocrine carcinoma on the breast. It just happened on the skin of the breast. So just to give an idea that so many years we've been seeing and reporting so many thousands of breast carcinoma, but in the breast, the proper small cell neuroendocrine carcinoma or even large cell neuroendocrine carcinoma are actually extremely rare. And most of them, if you do the markers properly, are more of IBC with neuroendocrine differentiation, as madam pointed out.
Yeah, and here the neuroendocrine markers will not make any difference, present or absent.
Therapeutically, it does not have any significance.
Yeah, thank you for that. It's a very important point, ruling out a primary, that is metastasis from a primary elsewhere. When you see a small cell or a large cell neuroendocrine carcinoma, it's a very important point. Thank you for that. And somebody wants to know your experience of HER2 positivity in mucinous carcinoma of the breast.
So I would like to defer that question till next time, because I know Dr. Ayushi is going to discuss everything in detail. We can have a discussion. We can keep it in mind, and Ayushi will go through that in detail.
Then we have yet another question. How to differentiate micropapillary carcinoma with neuroendocrine differentiation and NET?
Again, morphology is the clue. First, look at the morphology. Micropapillary has a typical morphology with those retraction artifacts and nuclei pointing out that micropapillary features. While the neuroendocrine carcinomas, as the case which I showed, I've shown both the cases, typical cases. So neuroendocrine carcinoma has that nesting pattern. And on type of that, micropapillary, we may not see that nice neuroendocrine differentiation so often. As I said, there will be sometimes maybe occasionally patchy synoptophasin or chromogranin positivity, while neuroendocrine carcinomas will express the neuroendocrine markers very nicely. Micropapillaries are usually ER positive, almost always ER positive, while the neuroendocrine carcinomas will not be ER positive.
Thank you for that. And we have an excellent question from Dr. Smita. Atypia and apocrine lesions, how do you report it in core biopsies, especially in glandular proliferation like DCIS?
So that itself is a topic of one lecture, because, as I said, differentiation between usual ductal hyperplasia, atypical ductal hyperplasia, and DCIS is always a problem. On top of that, when you have apocrine features and then there is nuclear atypia, it will be very difficult to differentiate. We may use sometimes markers, which is kind of surrogate markers. Whenever any intraductal lesion, which may be like atypical or DCS, like which has apocrinish features, one useful thing is if we can use HER2 and androgen receptor. Apocrine features, the cells with apocrine morphology, they are androgen receptor positive. But we have to remember sometimes TCI cells with HER2 positivity, they may mimic apocrine appearance. Especially on core biopsy, we may not be able to definitely say that. Now, differentiation between ADH and DCS, we use usual criteria that we uniformity of the nuclei and having nice cytoplasmic borders, all this. Right now, I don't have picture with me, but it will be a good point next time if I'm discussing to show all these things. Anywhere atypia, just report it as atypia. If you have access to immunohistochemistry, you can try to get these two markers. And if you don't have, you can say that apocrine features with atypia. The surgeons have to look at the radiological findings, everything together, if they will decide whether they should remove or excise the lesion or follow it.
The next question is how to differentiate type B mucinous carcinoma from invasive breast carcinoma with mucinous areas.
On on core biopsy, it may not be possible. So the core biopsy usually, if it is type B, we will. I'm suspecting type B. Type A is usually easy. You know the lakes of mucins are there with few carcinoma cells. But when it is type B, or sometimes you can have solid papillary carcinoma with some mucin lakes. That time you better say that this is invasive breast carcinoma with focal extracellular mucin present. We don't have to always give specific diagnosis on the biopsy if it is not possible. First of all, important is diagnose malignancy. Once we diagnose malignancy, try to give grade and special type if possible. What is important here is grade is important and biomarker whenever possible, this is important. We need to understand whether it is a primary breast carcinoma or it is metastasis from any other site.
In papillary lesions of breast, is true cut biopsy enough to call it benign with myoepithelial positivity? Or should we always ask for an excision?
So sometimes it can be if we get a very good lesion, you're never going to get entire lesion. But a representative biopsy, if you have nice papillary course, we can always say that this is a papillary neoplasm. We favor intraductal papilloma, and final diagnosis can be made on excised tumor. But it is possible, not always possible, I would say.
So when you get normal breast tissue only in core biopsy, would you ask for a repeat biopsy? Or
That's a very important thing. First of all, as I said, we are lucky that we have access to electronic medical records. So we try to look at what is the indication for biopsy. If they are suspecting malignancy, we usually go deeper sections. At least once I will have step sections on all the paraffin blocks, will get it. If still I don't see anything, I'll clearly mention that this shows benign breast tissue, while the radiology or clinically there is lump. So a repeat representative biopsy is essential.
and what would you call as adequate for subsequent biomarker study? How much should be there in the core?
So how much, there is no limit for how much, but there is no actually lowest number, how many tumor cells should be there. But we have to see whether the fixation is good or not, whether there are no crushing artifacts or any other artifacts. With this, if we have a good number of tumor cells, if the morphology is adequate, is good, then we can always give the um, biomarker evaluation. But I think, again, Ayushi should cover it the next time, when to repeat biomarkers in repeat biopsy or excised tumor. That itself is a separate topic. So, but then all these points should be taken into account, and I don't think there is any cutoff for that. Below this level, you should always ask for repeat biomarkers. There can be n number of reasons where we can't ask for biomarkers repeated on another biopsy or excised tumor.
Nina, is it time to wind up or any more?
Yeah, I have 2 or 3 questions to Dr. Ashavari.
Yeah, go ahead.
Yeah. We usually see these some of these core biopsies coming up, not only core biopsies, excision biopsies also, where the morphology looks like typical lobular carcinoma, invasive lobular carcinoma, but then E cadherin is retained.
Yeah.
And it's got the immunoprofile of also lobular carcinoma. So what is your experience with such?
So I think we do get this case, but I'm going to pass this question. Are you there, Ayushi? Because Ayushi has specifically studied these cases with showing lobular growth pattern. So why don't you answer that, Ayushi?
Yeah, thank you for that good question. Actually, this is a common problem a lot of people encounter when reporting core biopsies, that it looks like a lobular pattern. You are having single cell file, what looks like linear trabeculae. So we did a extensive study on differentiating, can we differentiate between proper true lobular carcinoma versus what is described in literature as IDCL, that is IDC with lobular features, which generally show retained E cadherin, and how can we distinguish them. So we found that our true lobulars are 95% or 98% nearly always ERPR positive, even if they have high grade morphological features, even if they are the pleomorphic lobulars. They are except for very few pleomorphic lobular, by and large all classic, all pleomorphic also are ERPR positive. While if we go for the IDCL, they are more likely to be in trabeculae rather than resembling lobular pattern, rather than actual cell discohesiveness. The cells don't shrink away from each other as they do in a lobular carcinoma. What it looks like a linear pattern. If you go and see in high power, you will see cell to cell adhesions. That is, the cells are arranged in a line with cells adhering or sticking to each other rather than being discohesive. This was in morphology, and of the cases that we studied, we found to our surprise that 30% of these IDCLs were actually HER2 positive. So the HER2 positivity also has a lobular type of pattern. So many of the HER2 positives we see, they have those abundant squamoid large cells, but there is also a pattern of HER2 positive which has these kind of trabecular infiltration, which many times gives rise to a question of whether this is a lobular. So if you are seeing it, your morphology, first of all, whether the cells are actually, and also you have to take into account very importantly fixation. If it is not a well fixed tissue, the cells are going to fall apart from each other regardless of whether it is lobular or ductal. So if it is a well fixed tissue, you will always find that if you go into hyper and look, the cells are actually sticking to each other. They are not shrinking away from each other. And the biomarker profile, if it is triple negative or if it is HER2 positive, you must take question their diagnosis of lobular.
So then what do you sign that out as? Invasive breast carcinoma, what type?
Lobular, yes. We call it rectal carcinoma, whatever grade as per the morphology. And
you call it NST?
NST with lobular features, yes.
Okay.
It is because as of now, it is not a WHO recognized special type. It is just
that's what I was also thinking. Why is that's not come up in the WHO?
Because actually when we did the study, we realized that they are not, mostly head-to-head comparisons of ILC have been with IDC in general. There are not many head-to-head comparisons with this particular type. There is also a dichotomy because most of the time we are using only E cadherin as a diagnostic marker, which is a very good marker for around 95% cases. But there is a small 5% where it can be a little wishy-washy, weak, focal here, there. So nobody knows actually what to call them. And actually CDH mutations, which is the marker for, the E cadherin loss, that is not practically possible for even, internationally to do in every case. So it is not like every case is genetically confirmed. So except aside for that very small population of where that E cadherin could be a little bit wishy-washy and not a very confirmatory marker, by and large, if you go by E cadherin, you are most of the times right. And then if we look at the morphology, it does turn out that it is looking lobular because of the pattern, but actually the cells are not breaking away from each other.
Is they give it as with a lobular pattern of invasion.
Yes.
Yeah.
Many
carcinoma, lobular pattern of invasion. That's what we.
And Dr. Ashavari, do you have any difficulty in differentiating fibroadenoma from benign phyllodes?
Always. As I said, if it is a cellular fibroadenoma and the age is somewhere between 30 and the size is also not giving any indication, radiology is not giving indication. Sometimes our report goes as fibroepithelial neoplasm. We cannot distinguish between fibroadenoma versus phyllodes tumor. But if it is young age and
How do they
sorry,
proceed? Like if you put those two
so
definitions.
they put everything together, radiology and clinical picture, everything put it together. That is excised, but they will not go for wide local excision if their clinical diagnosis is more likely fibroadenoma. So depending on that, not always we are going to get wide local excision, or maybe there will be thin rim of color of benign breast tissue. But as long as it's between benign phyllodes tumor and fibroadenoma, it's not a problem. Problem happens when benign phyllodes versus borderline, we can't say it's a bigger tumor, then whether to go for mastectomy versus just a wide local excision is a problem that time.
One other question. Do you use PDL1 on core biopsy? Do you do it?
Again, yeah, we do, but I think this will be again addressed by, I think Aisha will be covering next time. Am I right?
Yes, ma'am. Yes, ma'am. I'll be covering.
Yeah, sure. So I think we'll wait till Aisha's talk is over. I see one more question, how to differentiate microglandular adenosis from acinic cell carcinoma. But I think the morphology is peculiar for microglandular adenosis, which is in the form of tubules. There may be some secretions, and the acidic cell carcinoma is very, very rare, one thing. So is microglandular adenosis. But acinic cell carcinoma with its typical morphology is resembling salivary gland tumor, amphiphilic cytoplasm and all. And there should not, I think morphology should be diagnostic for acinic cell versus macroglandular adenosis should not be a problem on morphology. If at all anybody is facing a problem, best is to go for markers. S100 is nicely positive in microglandular adenosis, and acinic cell carcinoma, as usual, we can use DOG1 and other markers.
So I think, thank you very much, Dr. Ashavari.
Thank you.
It was a wonderful talk and a wonderful discussion with lots of questions. And so I think we'll wind up, Dr. Deepa. You're mute, Deepa, you're mute.
Thank you, Ashavari Madam, for the wonderful session, sharing your knowledge and experience with us. And we are sure that the residents and the practicing pathologists would have benefited well with a variety of case-based discussions. And yeah, I also thank Anita Madam for moderating the session so nicely. We also thank all the panelists and delegates for their active participation. IAPM office also extends our sincere thanks to Mindray Group for providing the platform for the webinar series and also for coordinating well. And at this moment, we would also like to remind the delegates about the quiz, which is based on the webinar series and will be conducted at the upcoming chapter meeting. And looking forward to meet you all next Friday, same time, for the third session. The topic is biomarker testing in carcinoma breast by Dr. Ayushi Sahai, again from TMH Mumbai. Thank you all.
Thank you very much. Thank you all panelists and even participants and the organizers.
Thank you all. Thank you, Anita.
Thank you.
Okay. Okay. Good night.
Night.
Good night. Anita Madam?
Yeah, good night. Thank you.